I think welcome to everybody on the second topic on the obesity, a very, very interesting topic for everybody and interested, I think A to Z from adolescent to menopause, everybody is into it. Will you please introduce?
Good morning. Today's speaker is Dr. Sachin Chittawar. He's a famous endocrinologist of Bhopal. He needs no introduction otherwise. Everyone knows about. He is MD in DM. And he is guest faculty of multiple national and international conferences, and including CF's IMSCON, Q, EPICON, Diabetes India Conference, FOXY programs, and he's having his own clinic also. So I invite Dr. Sachin Chittawar to give the talk on the medicine, which is very talk of the town. Ozempic and Monjaro is now talk of the town, and then obesity is an epidemic nowadays. Kindly.
Thank you, ma'am, for the kind introduction. First of all, I will like to congratulate the organizers of this a beautiful conference, National Conference on Indian Menopause Society, Dr. Srivastava, madam, and her team. To talk about the pharmacotherapy for obesity in women across the reproductive lifespan. So I have limited my lecture around data for women. The something good about Mohit has given the initial excerpts with respect to the pharmacotherapy also, because nowadays majorly the pharmacotherapy is also being taken over by the bariatric surgeons. This is also true. So it was some 10 years back when we discussed regarding this GLP analogs and we started using it in a very large number. So the therapy, when it comes to how many years, how many months, how many days I'll be taking the molecule for weight loss, dear friends, it is going to be a story which will continue lifelong. One of the young girls who visited few days back was just saying, sir, ab hame uncle bone lage log. So just I said, ki, uncle, kitne din lagenge? So I just said, ki, are you fond of burger? She said, yes, I love McDonald's. So I said, the 2 loaves of that burger, that is the 2 bread loaves, are going to be diet and exercise. They are not going to change. In between, the filling of a burger, that is the tikki of the burger, either it will be Monjaro, Wegovy, sometimes bariatric surgery, endoscopic sleeve, or many more interventions to come in between. This is how you will have to keep on having that burger if you enjoy that kind of savory food. This is how it is going to be the treatment of obesity in future. The first and the foremost thing, there are some tenets which are very important. If you are not at peace at your mind, you will not lose weight. That is the first and the foremost thing which is very important. Second is diet. Third is regular exercise. And that exercise will also keep on varying. Abhi just Dr. Varuna pointed out कि यार तुम्हारी भी थोड़ी tummy आने लगी. This is how the things are. I'm exercising regularly, but in spite of that, I will come across phases in my life where I'll have to regain what I have achieved over the years. Again, I will have to come on track and will have to work hard with respect to the that kind of zest is required when you are fighting with obesity. That is something very required. And third, foremost thing is make yourself spiritually healthy. We hardly are nowadays. So that's why the hedonic eating, the recreational eating, there are lots of things. Whenever we are very happy, we eat. Whenever we are sad, we also eat. Eating is that only thing which keeps on continuing. And that is something irrespective of your status, irrespective in what strata of society you are, that is continuing. So the pharmacotherapy of obesity in women across the reproductive lifespan, this is what the topic I have been given. So the worldwide prevalence of obesity in 2025, see the dominance with respect to the numbers. It is the females who are topping the chart. So this is how the data is. That's why I think the workshop has been kept. Why focus on women? Higher global obesity burden in women. This is established data. Greater body fat percentage at same BMI. Hormonal transitions influence adiposity. So nowadays we call it a disease of adipose tissue. That's why we need to address it throughout your life. Greater psychosocial and reproductive impact. So the social impact, the reproductive impact, and the psychosocial impact, that is with respect to mind, This is also something which is very important. So obesity in women, a lifespan of hormonal metabolic timeline with respect to puberty, where the estrogen goes up, the body fat mass goes up, and the early adiposity. It is physiological adiposity which sets in with puberty. Then during the reproductive age, you have this PCO or reproductive years, PCO problem comes in where the insulin resistance goes up. There is hyperandrogenism, there is central adiposity. At the bottom line, it is the adipose tissue which is at fault. Pregnancy also increase in placental insulin resistance, increase in fat storage, increase in risk for gestational diabetes, postpartum sleep deprivation, increase in stress eating, increase in weight retention. So many young girls who after delivery they come to us, Doctor, so nahi mil raha, because both of them are working. The wife is working and she's taking care of the kids also. That is a big social impact which we are not addressing till date. That is a very big problem during that time. Because the sugars are high, the blood pressure is high, the lipids are wavered, and they have started gaining weight. Whenever they go for they find some respite, that is something is in food only. They keep on eating and they keep on gaining weight. So the perimenopausal, again, the estrogen fluctuations, increase in visceral fat, increase in muscle mass. We have not taken care of this in the last, after 80s, I will say, after WHI. The hormone replacement therapy has gone into a kind of backstage. But we are talking about the 50% population, and we are not taking care of it nicely. What happens, most of you know what happens after menopause. That is again something which shatters so many things. It destroys so many beautiful aspects of your personality also, and might be adding something good, but this is something which is a challenge. And as a hormone specialist, we are not taking care of it nicely. And post-menopause, increase in estrogen deficiency, increase in sarcopenic obesity, increase in cardiometabolic risk. I will ask majority, there are a good number of people who are here, and just how many of you can stand without taking support? So there are people who will find it difficult to stand without taking support. From this chair only. That will show that there are people who are facing sarcopenia now. So that is again a problem which will create and which will increase. the doctors who are preventing cancers. We are the doctors who are preventing lot many. We are the doctors who are preventing or infertility also. We are the doctors who are increasing the ovulation with respect to our medications. So this is how the metabolic profile and everything has been clubbed up together. So we don't say in future, our doctors, the stream of doctors which will come, they will be metabolic doctors. So the credit goes to this dual agonist, a combination of GLP-1 and GIP, that is tirzepatide, Mounjaro. A popular dual agonist, that is tirzepatide, activates both GLP-1 and GIP receptors. So GLP-1, by activating its receptor, increases insulin secretion, and GIP is another insulin secretion agonist, which the people who are new to this, actually the moment we take something, a bite, there will be secretion of hormones from the gut, which we call as incretins. There are many incretins. GLP-1 is one of them, GIP is one of them, CCK and PYY and lot many other incretins. So in future, you might find so many use of the other incretins also in clinical knowledge. So this is how they have combined two incretins together, GLP-1 and GIP. And there is a synergistic action with respect to response, weight loss, sugar control, and lot many things. So tirzepatide, the mechanism of action, GIP. GIP increases satiety, decreases gastric acid secretion, increase in insulin secretion, increase in glucagon secretion, increase in adipose deposition. And this GLP-1 is increasing satiety, gastric emptying, and concentrate on this. It has got opposite effect with respect to GIP. It decreases glucagon secretion. The question may arise कि डॉक्टर साहब the same combination एक जगह आप ग्लूकेगॉन बढ़ जा रहा है, एक जगह ग्लूकेगॉन को सप्रेस कर रहा है. ये कैसा कॉम्बिनेशन हुआ? How can this be synergistic? This is something which people may ask. So the beauty about this is कि there is a triangle of things जो हम MBBS में पढ़ा करते थे फिजियोलॉजी में, जहाँ सोमेटोस्टैटिन होता था, ग्लूकेगॉन होता था और इंसुलिन होता था. इन तीनों का ट्रायड होता था, तीनों एक दूसरे को इफेक्ट करते थे. तो जीआईपी के साथ ब्यूटी ये है कि जीआईपी के साथ जब भी आपका ब्लड लेवल्स, शुगर लेवल्स 100 के नीचे जाएगा, तो जीआईपी विल टेक केयर ऑफ ग्लूकेगॉन. तो ग्लूकेगॉन को वो स्टिमुलेट करेगा तो क्या होगा? ब्लड शुगर विल गो अप. तो इट विल बी अ काइंड ऑफ check on hypoglycemia. But if it is sugars are more than 100, the GIP portion will not act on glucagon receptor. Those are alpha cells of the pancreas. The vice versa, आप बोलो कि GLP-1 भी आपने combine किया. तो GLP-1 के साथ क्या है कि it has got a suppressive effect on glucagon secretion. If the sugars are high and glucagon is stimulated, it will further increase the sugar values. So when the sugars are high, this glucagon will suppress it. So this beautiful interplay of GIP and GLP-1 has been incorporated in this molecule. So the molecule has got lots of science. And the way they have the combined effect is decrease in body weight, decrease in blood glucose. That is something phenomenal about it. And I have got so many patients who are actually surpassing their previous values of weight, and it has been beautifully shown in the SURPASS trials. SURPASS 1 to 6, now it is going up to 8 around. And they are now studying it, its effect on fatty liver, its effect on joints, it affects on even Alzheimer's disease. The ESSENCE trial is now talking about fatty liver disease, and they are showing the with respect to the costlier molecules. Resmetirom is the new molecule for fatty liver. It is an oral drug which is very costly. The ESSENCE 6 data is showing the molecule has got effect like resmetirom, but the molecule is not costly, not very costly like resmetirom, and easily available in India. So this is how the things are. So the SURMOUNT data with respect to SURMOUNT 1, 2, 3, 4 has been studied extensively, and the molecule semaglutide has been studied and compared with tirzepatide for weight loss. This is how your Ozempic or Wegovy and Mounjaro is with respect to at 3 months. Tirzepatide has got its more effect when it comes to weight loss. And see, this is at 6 months and 12 months. So mean percentage change in body weight at 3, 6, and 12 months receiving treatment for overall population. So triple agonist, now I was talking about, as of now, GLP-1 related triple agonists are primarily still in the development stage and have not been widely approved for use. These drugs are not yet widely available in the market also. Retatrutide, as Mohit was pointed out, a novel triple agonist developed by Eli Lilly that targets GLP-1 receptor, GIP receptor, and glucagon, and has shown potential in preliminary clinical trials and has now entered phase 3 trials at Mohak. I think Mohit has got that trial, so he's more versed than me when it comes to retatrutide. This is again a molecule of triple agonist developed by Hanmi Pharmaceutical in South Korea. It activates GLP-1 receptors, GIPCR, and glucagon, and has entered early clinical trials. Weight loss with retatrutide, tirzepatide, and semaglutide compared to placebo. See the phenomenal results of this molecule. With respect to placebo, when they are compared with placebo, it has got 5%, 10%, 15%, and greater than 20% weight loss. When you are talking about greater than 20% weight loss, it almost equates with bariatric surgery. So that is how he was talking about why there is so much buzz. He also started his lecture with oral drugs or with injectable drugs just because the era of obesity is directly or indirectly shifting towards surgery. Not surgery, oral medication. And in due course of time, you might require surgery as and when required, as he has rightly pointed out. So GLP-1 receptor agents in development for obesity treatment, what lies ahead? A new horizon, bright and clear, where health is found and progress is near. With science and hope as guiding light, the battle against obesity takes its flight. So small GLP receptor, orforglipron, in future this will be an oral molecule. It is almost comparable. The results are comparable with tirzepatide. Danuglipron, these are not survodutide and mazdutide and a lot many things. Very difficult to pronounce. I will end up my lecture with this case presentation. A 29-year-old woman present with a 3-year history of irregular menses, infertility for 2 years, weight gain of 12 kg over 5 years, BMI is 32, waist circumference is 96, on metformin, 3 failed cycles of ovulation induction. Labs, elevated fasting insulin, mildly elevated testosterone, normal TSH and prolactin. Diagnosis, it's very clear. It's very obvious and clear to you all. Polycystic ovary syndrome. A main metabolic barrier is obesity-driven insulin resistance. What should we do? Increase metformin, lifestyle alone, start GLP-1 receptor agonist, or directly send the patient for IVF? Any one of you. What are the choices we have? What is the best choice? Start GLP analog receptor agonist. This will help you in bringing down the weight. It will regulate the cycles and all those things also. Why? Because agents like semaglutide or liraglutide provide 10 to 15% weight reduction, improved insulin sensitivity, reduction in hyperandrogenism, and improved ovulatory frequency. Case 2, a 46-year-old woman, BMI is 29, waist is 104, new abdominal fat and fasting glucose is 110, HbA1c is 6, BP is 160, 146 by 90. Complains, I eat the same, what I gaining basically. The diagnosis, any one of you, what can be the diagnosis in this case? A perimenopausal central obesity. This is again an entity which is less addressed. The BMI less than clear, but clear central obesity plus metabolic risk. Do we treat weight pharmacologically? No, BMI is less than 30, only lifestyle, or start anti-obesity medication. What are your options? What can be the best choice? So it is C, start anti-obesity medication because BMI is greater than or equal to 27 with multiple comorbidities. Why? She clearly has metabolic comorbidities including hypertension, prediabetes, and the agents such as semaglutide, tirzepatide can reduce visceral fat, improve BP, improve fasting glucose, lower cardiovascular risk. In perimenopausal women, central obesity plus metabolic risk is equal to treat the fat, not just the BMI. So weight loss response to semaglutide in postmenopausal women with and without hormonal therapy. This is a new thing which is ushering nowadays. What the researchers found कि जब हमने tirzepatide वैसे ही दिया तो the weight loss was around 14%. पर हमने जब इनको combine किया hormonal replacement therapy से, estradiol से combine किया, in the form of patch, तो बहुत सारा metabolic problem भी नहीं था, complications were less. The weight loss rose to 19%. So this is again a new thing. Then they restarted, उन्होंने देखना चालू किया. Why is it so? When we combine hormone replacement therapy with anti-obesity medication, the weight loss response is good. It is the response of estradiol on your supramammary cortex, the POMC area, and the other areas of hypothalamus. It creates a milieu where the satiety goes up and the urge to eat goes down, and there is a reshift in metabolism. This was at the level of brain. What about the periphery? At the periphery, they thought just because of the estradiol replacement, there was decrement in the inflammatory markers, log decrement in inflammatory markers that also led to improvement in insulin resistance, that also led to good glycemic control and weight loss. Apart from that, they thought that the moment this estradiol has got its effect on vagal fibers also. So our beta cells, which were initially not responding to the GLP analogs properly, after the impact of estradiol, there was a huge impact. So in future, they might also combine the GLP analog with estradiol so that it might stop with respect to, you will not be worried about the thromboembolic events, the cancer risk, and the other metabolic parameters. So this is how the story is going. This is a new thing which has been added with respect to weight loss and GLP analogs. Hormone therapy boosts tirzepatide weight loss in menopause, in postmenopausal women with overweight or obesity. Treated with tirzepatide, hormonal therapy use was associated with an improved weight loss response. To summarize, obesity in women is hormonally influenced and life stage dependent. Weight gain patterns differ during puberty, PCOS years, pregnancy, perimenopause, and postmenopause time. Pharmacotherapy is indicated when BMI is greater than or equal to 30, BMI is greater than or equal to 27 with comorbidities. GLP-1 based therapies have transformed obesity management with 10 to 20% weight reduction. Potential agents such as semaglutide and liraglutide, they improve a lot with respect to weight, insulin resistance, and cardiometabolic risk. Dual agents like tirzepatide show greater efficacy in many patients. In PCOS, weight loss improves ovulation fertility outcomes. In perimenopause, visceral fat drives metabolic risk. Treatment should target adiposity, not just BMI. Thank you. Thanks a lot.
Hello. Is it audible? Yeah. Sachin, it was a wonderful lecture because it was supposed to be like that. And where did we start and where did we end? What is the future for us, generations? How many of you remember Pavlov pouch?
Yeah.
So that feeling of satiety will never come to us now. We have become gluttons to that an extent. So we will need all these hormones, we'll need all these surgeries, and perhaps somewhere along the line we have to control the sale, not make them like the MTP pills. Because what I heard lately was even the beauty parlors are prescribing these drugs. Can the industry control that? Should they control it? Or should we have an epidemic of other problems along with these weight problems which will be increasing because of the misuse of these drugs? So they have to be used under regulations only.
Yeah.
Should we start that thought process in time before it's too late? And congratulations again to Bhopal Menopause Society and our Indian Menopause Society, Dr. Anita Shah, everybody for making this a beautiful, beautiful organization. Yes, these are topics of controversy, they will always remain in controversy. But thank you for updating us on these new products. Thank you very much.
Thank you.
Congratulations, Sachin. That was a wonderful talk, and you explained everything very precisely. But there's one question, is that, of course, whenever we suggest or propose these medications to people, awareness is quite a lot in the society,
Yeah.
but it is still attached to a lot of apprehension. So, कि मैम कुछ होगा तो नहीं,
Yes,
pancreatitis हो जाती है
True.
मैम.
Very
So
true.
is there any specific type of a profile of a patient where you are coming across which are more prone to, the side effects? And what are those determinants where you cautious them specifically? Who are the people who will basically, fall trap to the complication
True.
profile of these
True.
medicines?
See, first of all, there were a lot of apprehension when the drug was launched some 15 years back. I'm talking about exenatide and liraglutide. People were very skeptical about pancreatitis, pancreatic cancer, and other comorbidities, which were heard, and till date we are talking about it. But over the years, none of the trials have shown increase in propensity with respect to, or increase in chances with respect to pancreatitis. If someone has got medullary thyroid carcinoma, if I will see a person, a young lady comes to me and examine her neck and she has got a nodule, I will go for the calcitonin levels. If the calcitonin levels are normal, I will start the therapy. Firstly, if a lady has got gallstones and the instability is there with respect to that dislodging of that gallstone towards pancreatic duct, definitely I'll be little bit cautious. But this is a relative contraindication for starting the medication. If my diabetic person is overweight and she is coming to me for weight loss, and during screening, I found that her retinopathy is there, and that is little bit towards the progressive side, I will not give this molecule. So these are few things which are to be taken care of, and mostly it is not there in majority of our patients. And when it comes to pancreatitis, our diabetics, being a diabetic patient, you have got five times more chance of getting pancreatitis as compared to normal population. And when you see the data of diabetics developing pancreatitis with or without this drug, there is no difference. So that is again one thing. And nowadays we are talking about ANION, that is sudden blindness, which has been associated with this molecule, and people are very scary. कि डॉक्टर साहब मैं अंधा तो नहीं हो जाऊंगा, मैंने पढ़ा है अखबार में कि इसमें इन दवा को लेने से एकदम से अंधे हो जाते हैं. तो एनायन के इंसिडेंस जब आपको when they saw in literature, there is a big study nowadays and there are not many studies which are going. उन्होंने देखा कि जनरल पॉपुलेशन में जब एनायन विदाउट मेडिसिन और विथ मेडिसिन जो हो रहा है, इट इज ऑलमोस्ट सेम. Right now we have got no direct link of anion with the molecule, but there is an association of anion and this molecule. It is there. It is associated, but it is not directly linked. And it is associated, what it is being associated in the common and general population also, who's not taking the medicine. The incidence rate is almost similar to the drug with the people who are on drug. So these are the major apprehensions. But the one more thing is, this is not a magical pill. This is one of the options. One of the options you have for obesity control. This is not a magical drug, which हम कहते हैं ना, ये रामबाण दवा नहीं है. This is what people think कि 20,000 रुपए की दवा है तो then something रामबाण has come in और इसको लगाते ही मैं दुबली हो जाऊंगी, ऐसा नहीं होने वाला. You will have to stick to diet, exercise, जो मैंने पहले tenets दिए ना, diet, exercise, 6 to 8 hours of sleep, no tension तनाव. These are mandatory things, but it is very difficult to achieve these 4 things in life nowadays. If someone is not, he is restless, he is very much in stress. So I have got so many patients who are not losing weight, even on this molecule. This is also true. The non-responding rate with respect to this is, in research also, 20% of the patient, they don't respond to this molecule. 80% they do respond to this molecule, but over the top of it, you'll have to be very clear with respect to diet, exercise, 6 to 8 hours of sleep, and no tension tanav. That is something which should be the 4 tenets of obesity management.
Just wanted one clarification. Lancet had come up a new definition of obesity beyond BMI
yes,
in
true.
2025.
That it
What do
talks-
you have to say about
It
that?
talks about adipose tissue. It is talking about adiposity that as a disease. And that is something which needs to be catered throughout life. That is what it is talking about. It is about talking about the inflammatory markers, which it is the adipose tissue, which is basically, it is a disease of adipose tissue. It is not just weight. It is the fat which is ill.
So actually it's a metabolic disease.
Yeah,
So
true.
gynecologist, as a gynecologist prescribing, I think I'll have some inhibitions about it. So should I be referring to the physicians only?
I'll be very happy if you are referring the patient to me. But that is also true. See, in whatever amount you are well versed with, ideally, if I've been asked to conduct a delivery, I will not be able to do it. I will definitely refer the case to you. This is how the things are. But the way the morbidity and the kind of prevalence of the disease is increasing, each and everyone should know about diabetes, hypertension, obesity, because in every second or third patient, you will be encountering these challenges. So this is also important. That's why such kind of lectures and presentations are also important.
So to my understanding, जो मुझे समझ आता है कि this would be good for some time, कुछ tide over करने के लिए वही जैसे शादी करके, but then eventually the sustainability would be those three, the lifestyle, the diet, the
नहीं, over the top of it, मैडम ऐसा है कि आप बर्गर तो आपने बना दिया, उसमें आपको सेव भी डालना पड़ेगा, कुछ लोगों को मेयोनीज पसंद है, कुछ लोगों को कुछ इंडियनाइज करते हैं तो इंडियन हर्ब्स और बाकी सब चीज़ें भी डालने लगते हैं. सो ये आपको लाइफ लॉन्ग लगेगा. You will be requiring some kind of therapy, either in the form of orlistat or GLP analog or bariatric surgery or sleeve or lot many other procedures which will come in future. So it will be basically it will be a team effect which will give you a very good response in future. Because or vice versa, चिरयौवन और चिरायु जीवन सबको चाहिए ना सबको. 100 साल का भी जीवन चाहिए और बिना बीमारी की सुंदरता वाला भी चाहिए. तो चिरयौवन और चिरायु जीवन के लिए ये 4 ही टेनेट्स काम आते हैं जो मैं आपको बार बार बता रहा हूँ. तो वो चीज़ें आपको ओबेसिटी की ट्रीटमेंट में मिल जाएंगी. तो देयर इज नो हार्म इन कंटिन्यूइंग विद दोस ऑल 4 पिलर्स एंड ओवर द टॉप ऑफ इट टेक हेल्प ऑफ डॉक्टर भंडारी, टेक माय हेल्प एज एंड व्हेन रिक्वायर्ड, एंड वी कैन डिलीवर द पैकेज, द कंप्लीट पैकेज ऑफ ओबेसिटी मैनेजमेंट.
How long we have to continue this treatment?
GLP analog, the moment they have lost weight,
Cost incurring this treatment?
GLP analog right now, Monjaro is costing around 15 to 20,000 rupees a month. Semaglutide is around about 10 to 15,000 rupees a month. The good news is that it is getting off patented very soon. April onwards, around 100 Indian companies who are waiting, the brands have been registered already. So they'll be launching. So there will be more competition. The present price, what they are saying, is around 4,000 rupees a month for the molecule. So this is a big change. But I am saying that the golden era for diabetics is coming, and for obesity also. So even some of them are claiming that हम तो 500 रुपए में एक पेन दे देंगे आपको. So this is how the things are. तो हो सकता है some in the few months from now मेरा हर दूसरा patient will go on this molecule.
Sir, it's $1 billion industry, and it's audible. Yeah, I think we'll have to start from teaching our kids how to brush the teeth.
Yeah.
The lifestyle modification, they have to start
Very
from
true.
the families itself. Until unless we change the families, we change our structure thinking, we will continue with the advent of the new drugs, new surgeries, and we will all be welcoming you and enjoying your lectures. Thank you very much.
Thank you, thanks a lot. पुराने ज़माने में लोग चौपाल पे बैठ के बीड़ी पीते थे. आज हम लोग उसको बहुत बोलेंगे कि यार ये तो क्या है, पर वो सुकून और वो सेटिस्फेक्शन आपके जीवन में आज नहीं है. आई विल लाइक टू एंड माई टॉक विद दिस. थैंक यू.